Hello and welcome to Insight Ophthalmology. I, Dr. Amrit, welcome you to the series on BSCAN ultrasonography. Today we are studying the basics of BSCAN. The concept of ultrasonography was adapted from bats. It is believed that the bats cannot see. However, they produce sound waves at frequencies which are above human hearing. Usually this frequency is considered to be about 20 kHz. So bats will produce sound waves which are above 20 kHz, and this sound wave is called the ultrasound waves or the sonic waves, right? So these sonic waves, when they are emitted out from the bats, they will go and come in contact with the target. The sound waves will now be bouncing off the objects which are present in the environment, and again this, because of the bouncing back, they will be reflecting back again to the bat. Right, so the sound waves which are reflected back after bouncing from the target are called as the echoes, right? And by studying these echoes, actually the bats and also dolphins for that matter, they can navigate their path and they can find out exactly at how much distance is their prey located. So this process that bats use to locate their target or prey using the sonic waves, that is the waves, acoustic waves which are greater than 20 kHz to find out the location of their target, this process is called echolocation, right? So because the location is being found using the echoes which are reflected back of the target, this is called echolocation, right? Now by studying the principle of echolocation and by studying the bats and the ultrasonic waves or the acoustic waves, the principle and the methods of ultrasonography were developed, and ultimately we started using ultrasonography in ophthalmology as A scans, B scans and orbital scans and so on and so forth. So the basic principle of ultrasonography is that we have an ultrasonic waves which are nothing but the acoustic waves or sound waves that by definition will have frequency greater than 20 kHz, which can also be written as 20,000 Hertz, right? And let me tell you, 1 Hertz is nothing but 1 cycle or 1 oscillation per second, right? So they are acoustic waves. These acoustic waves are generated by vibration of the piezoelectric crystals which are present in the probe. So if this is considered to be the BSCAN probe, right? This is the BSCAN probe over here, and we have a mark which can be seen on it in white color. Sometimes it might be in red color also. This probe actually consists of certain crystals, right? And these crystals are going to vibrate against themselves, and their vibration will produce sound, right? After all, sound is nothing but vibration, right? So their vibration will produce these acoustic waves, and these acoustic waves will then be generated and directed towards the target tissue. And in this case, what is the target tissue? It is the eye, right? Because we are doing the ultrasonography of the eye. Now, before we jump into the details of BSCAN, it is very important to know what is the relationship between the frequency and wavelength of an echo. Whenever there are more number of waves or more number of oscillations present in a second, it means that that particular vibration is having higher frequency, right? So what I mean to say is, as in this example, more number of waves are fitting in 1 second. That means this is a higher frequency wave, right? And always the frequency and wavelength have an inverse relationship. That means whenever the frequency is more, the wavelength will be less, right? And wavelength is nothing but it is the distance between two waves which are in the same phase. So if this is considered to be the crest, let me tell you, just a second. Yeah, so if this is considered to be the crest of the wave and this is the crest of the wave, and these two are the troughs of the wave, right? So the distance between the two crests or the two troughs of a wave is nothing but wavelength, right? So as you can see over here, in this particular example, there are so many waves which are fitting in 1 second. They are tightly packed, right? Now, because they are tightly packed, what is happening to the wavelength? The wavelength is less. So, in the case of high frequency wave, the fine frequency wave, the wavelength will be shorter, right? Now, wavelength decides how much depth a wave can penetrate, right? So, whenever we actually have a shorter wavelength, it means that the depth of penetration of that wave will also be less, right? So this wave like this, it cannot penetrate much deeper, right? The depth will also be less. However, because there are so many waves which are passing through one place, the resolution will be more, right? So the resolution will be more, right? Now, considering another wave in which the number of waves are however less, right, as shown over here in this diagram in 1 second. Now, such a wave is called a low frequency wave. Now, as you can see that in a low frequency wave, however, the distance between the two crests or the two troughs is more compared to the previous example, right? So in a patient who has low frequency vibration, the wavelength will however be longer, right? So low frequency means longer wavelength. If the wavelength is longer, the wave is longer, and therefore the depth of penetration of that wave will be more, right? So that is the reason why we are using low frequency ultrasound that has longer wavelength and therefore greater depth of penetration for the abdominal ultrasound, right? However, for the ophthalmic ultrasound for our eye, which is comparatively much smaller compared to the abdomen, we are using a higher frequency ultrasound which will have a shorter wavelength because we want lesser depth of penetration. Okay. However, as I told you that in high frequency, because there were more number of waves, the resolution was better. In low frequency, however, there will be less number of waves in 1 second and therefore the resolution will be less. So for an abdominal ultrasound, the depth of penetration is more because we are going deeper into the abdominal structure, but the resolution will be less. However, for the eye, whenever we do ultrasound, we use high frequency ultrasound because the penetration, we do not need much penetration, right? Therefore, we use high frequency which will have a shorter wavelength, but the resolution will be more, right? Because more number of waves are fitting in that 1 second gap. So this is how it is, right? For the anterior, if we have to say image or do ultrasound of the anterior eye segment, right, that is before the lens, which is what is called UBM investigation also, which is nothing but ultra biomicroscopy, right? So in that case, we will be using the maximum frequency ultrasound, that is from about 25 to 50 megahertz. However, now if you want to go from the anterior segment to the posterior segment of the eye, in that the type of frequency that we use is about 10 to 15 megahertz or about 20 megahertz. However, if we want to go further behind the eye, that means we want more amount of penetration to image, say, the orbit, the frequency will further decrease now to about 10 megahertz. Now, our sound waves, they are going to travel uninterrupted if they are passing through a media which has same density throughout, right? So if this is considered it to be a sound wave which was traveling at a speed of 5 meters per second, just imagine that it will travel with the same speed throughout this media because the density of this media is same. However, when the sound comes in contact with another media which has different density compared to the previous media, the speed of sound will change depending upon the density of that media, right? So it is very similar to the concepts of the light waves, how light waves travel. We know that whenever a light strikes a surface, what happens is either it gets reflected, right, or it gets scattered, or based on the density of the media, it might get refracted also, right? So the same principles you can apply for the sound waves also. So whenever the sound waves are traveling and they come in contact with a surface which has different density, either less density or more density, the echoes will actually change based on how much is the absorption of the sound by that medium. So what I mean to say is, if there is a medium which is less dense, what happens is this less dense medium has more tendency to absorb the sound waves. And this property of a less denser medium to absorb the sound waves is called sonic absorption, right? So this is called sonic absorption. Now what happens because of the sonic absorption is that the echoes which will come back from this media will be smaller compared to that of the lesser media. So let me explain to you in detail. So what happens is, consider this to be a media, and this media is not as dense as this media, right? So what happens when we send this acoustic waves to this media, because the medium is not that dense, part of the energy of the sound waves will be absorbed by this media, right? And only a part of it will be reflected back. And as I told you, the reflected back thing is called the echo. Now, because part of it is absorbed, the reflected echo will be weaker, right? It will be weaker. Compared to that, in a more dense media, what happens is this media is already dense. It is full of its own material, right? So when we send a sound wave into this material will not be able to absorb much amount of the sound waves, and therefore it might reflect the total amount of the sound waves which we have given it, right? Therefore, the echo which is coming from a more denser medium will be much stronger echo, right? So if you know this concept, next what we can go on to is the concept of acoustic impedance and echo, right? So acoustic impedance is nothing but, in simple terms, it means the ability of a medium to resist the transmission of an ultrasound waves by the virtue of its density. That means if there is a denser medium, that denser medium will not allow the sound waves to pass through it, because it has its own material in abundance, and therefore it will reflect the sound waves back. And whatever sound waves do travel through it will travel very slowly, and they will not even be absorbed, right? On the contrary, if we have a less denser medium, the sound waves will be more easier to pass through. It will be more easy for the sound waves to pass through it. The speed also will be more. However, they will get absorbed in the process, and the amount of sound which is getting reflected back will, however, be less, and therefore the density of the echo will be less and the echo will be weak. Second is, I'm talking about echo. So what is meant by echo? Echo is nothing but whenever the wave will strike the acoustic interfaces, right, of different acoustic impedances, greater the acoustic impedance, the difference between the two media, greater will be the strength of the reflection of the sound wave, and therefore greater will be the strength of the echo, right? So echo is nothing but it is the reflected sound wave, right? If the density of the media to which it is striking is more, the impedance will be more, and therefore the echo will be stronger. However, if the media is less dense, the echo will be less dense because the reflection will be less. Therefore, what is BSCAN ultrasonography? BSCAN ultrasonography is nothing but it is a simple non-invasive tool for diagnosing the lesion of the posterior segment of the eyeball. In ultrasonography, an oscillating sound beam is emitted by the vibration of the piezoelectric crystals, as I told you, and then they will pass through the eyeball. They will be imaging a slice of the tissue, and then the echoes will be produced, which are nothing but the reflection of those sound waves, and these are finally received back by the transducer, and we will get an image of that slice on the monitor. Now let us talk about the four basic components of a BSCAN. The first component is this pulsar, right? So as shown over here this is our pulsar, right? The pulsar is nothing but it is a source which will generate the oscillatory signals, right? So these oscillatory signals will then go to the transducer or the probe. In the transducer, we will have the piezoelectric crystals, okay? They will be stimulated and then they will make the acoustic waves or the sound waves. These sound waves will now be traveling into the eye. In the eye and from its various structures, they are going to get reflected back as echoes, right? It is called the reflected echo. Now this reflected echo will again be collected by our transducer. This transducer will then be sending these echoes to the receiver. Now the function of receiver is to amplify the echo that we have received from the transducer. After it amplifies those echoes, it will convert those echoes into this image over here, right? And this is the image which is a two-dimensional display of the tissue of interest or the slice that we have taken from the BSCAN probe, okay, on the monitor, and this is our BSCAN report that we see on our monitor, right? These white dots that we see on this images are nothing but they are called the dot echoes of the BSCAN. So there is a difference between the A scan and the B scan. The A scan is called the amplitude display mode, and the B scan is actually called the brightness display mode, right? A scan is actually a one-dimensional ultrasonography procedure. However, B scan is two-dimensional. What we do in A scan is only a single acoustic wave will be passed through the eye, and its reflection as an echo will be studied in relation to time. Based on the time and the velocity correlation, we will actually find out the distances in the eye. So what I mean to say is, we know that the speed of sound is different in different media, and we know how, with what speed the sound travels in our lens, in our cornea, in the vitreous, okay? And then as we send this sound wave inside the eye and it comes in contact with various surfaces, from a baseline the echoes will be depicted as these spikes, right? Various spikes. Now, based on at what time these spikes are being produced in the A scan, and using the formula that distance is equal to speed into time, as we know the speed of the sound waves and we know the time at which they are coming back, we are going to calculate the various distances in the eye, and that is how the A scan ultrasonography is used to measure the axial length of the eye, to measure the anterior chamber depth, to measure the vitreous chamber depth, the lens thickness, right? So every metric which is related to distance or length can be calculated using the A scan. However, this is a one-dimensional scan, okay? So in the A scan, the returning echoes are actually displayed as spikes from the set baseline. So greater is the strength of the echo, the taller will be the height of the spike. So this is the graph that we get after doing an A scan. You can see this is the first wave that we see and get from the probe, and then the cornea actually gives a double peaked spike like this, because the first one is coming from the anterior surface of the cornea and the second spike is coming from the posterior surface of the cornea. Then again we have a spike which is coming from the anterior surface of the lens, and then we have a spike coming from the posterior surface of the lens. Then we have an echo-free vitreous cavity, and then we have a spike from the retina, choroid and the sclera complex. And finally, we have the orbital fat spikes, which are actually decreasing gradually because their echoes are relatively weaker echoes. However, in a case of a B scan, which is called a brightness display, we have a two-dimensional display in which the strength of echo will be displayed as a dot on the screen, right? So remember I showed you those white dots on the screen which were actually forming an image of the eye. So those are called the dot echoes. The more brighter a dot, okay, the more is the strength of the echo, and echo is nothing but the reflected sound wave. Now, in a case of A scan, we were sending just a single wave inside the eye. However, in a B scan, we have a much wider probe, and this probe is going to send multiple sound waves into the eye in such a way that we are imaging a slice within the eye. So this is the image of a B scan, and we can see the various white dots which are coming together and making an image, and these white dots are called the dot echoes. The brighter the dot, the brighter is the more stronger is the echo, right? And in this image you can actually see that we can see certain waves similar to those of the A scan. So it is nothing but an A scan plus B scan, that is an A scan overlay on the B scan image, which is used in certain conditions to diagnose a few conditions, right? And when we use the A scan with B scan, we can actually be more sure about our diagnosis, right? Now let us try to understand a very important concept in B scan, and that is gain, right? So what is gain? Gain is nothing but it is a uniform amplification of the ultrasonic signal or the echo that is returning to the transducer after it travels through the tissue. I would like to explain the concept of gain using this picture over here. Let us consider this to be a box inside another box, right? The inside box is lighter in color because it is less dense compared to the outside box here, which is more dense. So when we are passing an acoustic wave, as I told you by the concept of acoustic impedance, the reflected wave will be much stronger from the part which is having more density, right? So the outside box will reflect the echoes which will be much stronger compared to the waves which are coming from the inside box. Now the inside box is having less density, therefore the echoes will also be weaker from the inside box. Now detecting these weaker echoes is much difficult when the stronger echoes are present, because say they have a score of about 30, they might be only 5, right? So there's a difference of about 25 in the strength of the echoes of the larger box and the smaller box. Now in gain, what do is we are going to amplify all the echoes which are coming from this structure, right? So say we put a gain and we amplify it by say another 30, right? By another unit of about 30, right? So what happens? The outer box echoes will become 30 plus 30, that is about 60, right? And the inner echoes are now becoming 5 plus 30, that is 35, right? So initially we were getting echoes which were so weak from the weaker box or the less denser box. Now we are going to get much stronger echoes even from that weaker box, right? And what will happen to the outside box? The outside box will send even more stronger echoes, right? So what will happen in this image? You can imagine that the image will be so bright. So we are actually increasing the brightness of the image, right? And by increasing the brightness of the image, what I mean to say is we have increased the gain of the image. And by increasing the gain of the image, what I mean to say is that we have increased the echoes by a certain unit. Okay, we have increased all the echoes by a certain unit. The stronger echoes have become more stronger. The weaker echoes have become strong enough that now they can be easily detected by our transducer and we will have an image of that echo, right? However, what has happened is all the echoes now are looking whitish in color and the noise of the image has increased. So let me tell you about it. So in gain, the image on the screen is whitened by a uniform margin so that the returning signal is stronger than it is and therefore it is easier to see that signal. So this is an ultrasound image in which we can see that this is our vitreous, and inside the vitreous we can see certain echoes which are coming from the posterior vitreous detachment and vitreous degeneration. Now the vitreous echoes are usually very weaker echoes and weaker signals, right? So when we put a low gain, we might actually miss that the patient is having a vitreous detachment, right? So in those cases we might have to increase the gain in order to see those weaker signals, right? So the first image over here is an image in which the gain is high. You can see that the image is so much whitish in color. So in such an image which is having higher gain, the weaker signals will be more clear and they will be better displayed. Okay, however, this image over here is actually having lower gain, and in the lower gain, the weaker signals, that is here the posterior vitreous detachment, is not seen, right? So weaker signals are disappearing, but it is actually having a better resolution of the strong signals which are coming from the retina and the RCS complex. However, when the gain is high as seen here, there is so much whitishness that we cannot differentiate where is the retina, where is the choroid and where is the sclera. Okay, so their resolutions have actually decreased in a higher gain. But in the lower gain, although the weaker signals disappear, the stronger signals will be better appreciated and their resolution will be better, right? So I hope this is clear about gain. Now, what are the conditions or indications of using a BSCAN? The first indication is the opaque ocular media. right? So opaque ocular media example is in the anterior segment. Matlab, the media is opaque because of the anterior segment, that is corneal opacity is present, or in the anterior chamber we have blood, that is hyphema, or pus in the anterior chamber, hypopyon, or the pupil is so small that we cannot carry out a dilated fundus examination, or there's a cataract present in the lens, or there's a pupillary membrane, right? However, similarly, in the posterior segment also there could be some problems in the media like vitreous hemorrhage or inflammation, right? So the first set of indications is the opaque ocular media, which will make the examination of fundus difficult. The second indication is even in the presence of clear ocular media, that is the anterior segment lesions like the iris lesions and the ciliary body lesions, whose depth and the three-dimensional structure might be difficult to be ascertained on slit lamp examination, and for those cases you might want to go for an ultrasonic examination. Similarly, in posterior segment tumors, for differentiation between the different types of tumors which will have different characteristics on BSCAN, we can use a BSCAN. Second, for choroidal detachment to know whether it is a serous detachment or a hemorrhagic detachment. In different kinds of retinal detachments also we will use the BSCAN, right? Especially to know whether it is an exudative type of RD in which shifting fluid can be demonstrated in BSCAN. Then optic nerve diseases, posterior uveitis and scleritis, in which we will see fluid in the posterior subtenon space. So for that BSCAN can be used, right? The third indication is in the presence of intraocular foreign body. So BSCAN can actually detect the intraocular foreign bodies which are lost in difficult situations, which are difficult to be distinguished on a normal fundus examination, their localization, and then finally even the orbital lesions, whether it is tumors, orbital foreign bodies, sometimes muscle inflammations also can be picked up on a BSCAN.